I wanted to spend, before introducing our speakers and getting immersed in their remarks, I wanted to make a couple of preliminary remarks about suicide and the response to suicide. Those of you that have attended trainings that I've organized recognize that I often want to begin with a live interview with a family member who's gone through this tragedy, because I like to begin the training celebrating resilience and recognizing what it is in this person's life, not necessarily just therapy, that's helped them to accommodate to a violent death from a homicide, a suicide, an accidental dying, which makes up about 7% of annual deaths in the United States. But it's the most frequent form of dying before age 40, so that it's particularly impactful on young families. I've been interested in this for decades as a psychiatrist. But I've been more interested in what helps people beyond therapy to accommodate. And the model, I think, is one more of prevailing than recovery. I don't think after a violent death anybody is ever the same as they were before in terms of their view of themselves or the future, because I think of the depth of attachment with the person that's died and the way that they have died, which is, as I see it, very different than a natural dying. Probably only 20% of people who experience the violent death of a loved one are going to have a really enduring, disabling sort of response. So it's very important, I think, that we understand how the 80% of the people that are able to accommodate this, what sort of resilient capacities they're able to mobilize within themselves. What are the inner resources of strength and adaptability? Very, very difficult to measure. Indeed, although with our intervention, which is a 10-session group intervention, we use pre and post measures to document the impact of our intervention. I don't have a lot of faith in the measures. I think that often what people are going through are related more to these traumatic sort of images of reenactment of the dying, of remorse, that somehow I should have prevented this dying, because after all, unnatural dying from homicide, suicide, accidental dying never should have happened. And I think particularly mothers who lose a child from an unnatural death feel very, very central in terms of somehow preventing this, that there's something they could have done to have made it unhappen. Well, part of this, since I'm not going to present a family member, I don't have time to do that. I'm going to present a little bit about myself, because I've been through this myself. And you're going to be relieved you're not going to hear a detailed sort of monologue about what I've been through. Those presentations, I think, are sometimes uncomfortable for me to listen to, because often it's given with an air of not only change and prevailing, but somehow conversion, that I was this sort of person before this tragedy, and now I'm this sort of person, and I'm going to lead you to the light, because somehow I've not only prevailed, but it's been good for me. And I don't think it was that sort of an experience. My experience with suicide began in 1974. I began the section of psychiatry in 1972 and arrived with Julie, my first wife, and our two small children. We decided to have a third child, and she became very depressed while pregnant, and the depression really intensified when she had a postpartum reaction with the birth of our daughter, Wendy. When Wendy was a month old, she died suddenly from an intracranial hemorrhage. And so Julie and I not only lost Wendy, but Julie's depression spiraled, and she committed suicide a week after Wendy died. So at that point, I became very much a participant observer in the whole area of suicide and accommodating to it. I never sought any therapy myself. I think one of the ways that I maintained my resilience was by being resilient for everyone around me, particularly my two kids who were then 5 and 3. And getting back to work within a few weeks. I couldn't do psychotherapy, but I could do administrative work. I could see new patients for evaluations. The importance of establishing some sort of focus that was meaningful, that was alive, that was vital, because I think often the confound for a family member after a sudden violent dying like suicide that they were not willing to accept, and I certainly wasn't. There's a traumatic dimension to the dying that's different than natural dying. If Julia died from cancer, that is a dying that's internal, it's impersonal, it's no one's fault. I could have been a part of the dying story. I could have been there as her dying was diagnosed. We could have gone through a medical ritual of trying to save her. We could have said goodbye to her. We could have respected her. She would not have died all alone. I would have been there. In other words, the dying story that people are left with when it's sudden and unacceptable and is one of traumatic reenactment, and it occurs in flashbacks and dreams because you're not there when it happened. So it's surreal, and you have no control over it. Again, because you don't own the story. And sometimes the story that you're telling, the imaginary story, is probably much more traumatic than what really happened. So I recognized that I was going through this traumatic response, not just to the separation distress in terms of her death and my final separation from her. And that's an alluring sort of distress response. You want to get close to the memory of her when she was alive because that's comforting. It's meaningful. Very different than the aversive, traumatic imagery of her dying. And so this, psychodynamically, I think it gets confusing for family members after there's been a suicide because of these two concurrent distress responses that are going on. And the trauma distress takes precedence over the separation distress. And this is what brings people in for treatment 6 to 12 months later. Of the 20% of people that can't quiet their minds from this reenactment imagery or the imagery of remorse that somehow I should have prevented this. Very different than what happens when suicide is elective, which is, of course, becoming more common now. There are 3 states that will allow this, although you have to go through an incredible process to verify that you can go through an elective suicide. But I had a close friend and mentor, a neurologist, who taught me neurology when I began my training for 6 months, who developed a fast-paced slide into a neurologic disaster. It was never really established whether he had ALS or some sort of a malignant multiple sclerosis. But what a nightmare, particularly for a neurologist who not only could see what was happening to his body, but could diagnose and had a prognosis about what was happening. and made it very clear to all of us and to his family that when this began to interfere with his speech, that he didn't want to go on. And he was able to have long conversations with his family members about the dying. They've had an opportunity to not only join in the conversation, but an opportunity to tell him how much they loved him and respected him, and his dying was not transgressive to the family. And he had a cache of medications that he had collected, and he quietly died with the family members in attendance. It was not as traumatic because they could be a part of the dying. That's different, I think, suicidal dying, which is elective, when the family members can actually be a part of the dying narrative. Or when there's a long, long history of schizophrenia, or long history of some sort of physical disease that's not going to get better, that suicidal death contains more relief than traumatic grief. And I think it's important to differentiate those when we talk about suicide. That's different than homicide. Homicide, I don't think, is ever elective so far as the victim is concerned, nor is accidental dying. And in terms of the three dying, homicide is probably the more distressing of the three forms of dying, although it's the least frequent. So it's idiosyncratic. It's one of the things that I wanted to highlight at the beginning, that we're going to talk about bereavement after suicide, but it's different for every person. It's different as their relationship, and it's different as the story that they're telling themselves, and the importance of at some point injecting a story of their living to counterbalance the story of their dying. And this was something I discovered in myself, and I wrote about it in a book that I published in 2001. And this is not an advertisement. The proceeds, the royalties of the book go to the Separation and Loss Service. But I wrote the book for the public as well as for clinicians about my own experience. It's more of a monograph than a long book. This is what I wrote as I was struggling with this reenactment narrative that I was telling myself still after 6 or 8 months. And I was struggling to try to retell her life, get back in touch with that in terms of the retelling. And it began with our laundryman, because a lot of the people around me were giving me messages about her living that I was having a hard time hearing. It began with our laundryman within days of her death, and when I answered the doorbell, I could see in his flushed face and watery eyes that he'd been drinking again, and in one hand he suspended several of Julie's hangered dresses, while the other cradled an unopened bottle of bourbon. And he wordlessly handed me the bottle of bourbon, apparently to soften the hurt of the lifeless dresses. "Doc, I heard what happened." I could tell she was depressed, but we all get that way. "She wouldn't do this to you and your children. I know in my heart that she's still alive. She's gone off somewhere to get better, and then she'll come back." And I could smell his leather jacket and the bourbon on his breath, as he draped the dresses over my shoulder, drove off in his battered delivery truck, and I never saw him again. I finished the bourbon. I couldn't finish his story. That same week, my 4-year-old daughter announced that Julie was playing a game with us. She'd gone somewhere to hide, and she would surprise us by coming back soon because she missed us. I knew what this story meant to her, resurrecting of Julie and denying of her death, and she told the story for several weeks while I listened. I never challenged her, but reassured her that we would be okay no matter what had happened to Mom. And eventually she stopped telling it, but I couldn't forget that story either. And a month later, one of my schizophrenic patients told me that he'd seen Julie in Seattle. He was in the hospital cafeteria when he overheard 2 nurses talking about her suicide. and he felt very troubled. And that same day, he saw her crossing the street in front of the hospital. He'd never seen Julie before, but there was no question in his mind that she was still alive. I think he probably felt a mixture of compassion for me and fear that I might die, and telling me that she was still alive would comfort both of us. He never mentioned this sighting again. But I couldn't forget that story either. Well, I know that this magical thinking is the product of immaturity in my daughter, intoxication in my laundryman, and schizophrenia in my patient. And as a physician and a psychiatrist, I demand that my thinking be objective. I don't need to deny dying and death. Julie is dead. End of story. When death happens, there's nothing left to tell. Why then did my mind keep retelling those stories? I think it was because my daughter, my laundryman, and my patient were each giving me a restorative message. By logically and narrowly refuting their stories as magical, I dismissed the transcendence in their telling. In each case, their story of Julie drew me away from her dying and its retelling, and pointed me toward her living memory. The message and magic of their stories is that I can prevail over her dying by finding some meaning and coherence in my living memory of her. Julie is always with me if I let myself remember her. The importance in the model that I've developed of restorative retelling of reinforcing this shift from the violent dying reenactment and remorse to what I call the golden thread, which is a connection with the living memory of the person and commemorating that and celebrating that memory before you begin doing any kind of work. When I see someone for the first time for an evaluation of a traumatic grief after a violent death, I tell them the last thing we're going to talk about is the dying. I need to get to know you as a person before we begin talking about what's happened. And I need to understand how you've dealt with stress before, what sort of resources you have for strength. I am not at all religious, but I always ask about spiritual beliefs because of the enormous importance of spiritual beliefs with family members particularly after a violent death, because the image of the person in terms of the retelling isn't trapped in this narrative. I think if most spiritual beliefs believe that there's an ongoing connection with the spirit of the person who is in a peaceful space that might even promise reunion. So the importance, I think, of uncovering those sorts of resources, of resilience, before you begin getting into the dying kind of imagery and commemorating the life of the person. You invariably now, when you're talking with someone, usually a mother, with mothers who are coming in more often than any other family members, do you have a picture of Fred? I want to know his name too. How would Fred feel about your being here? How would Fred help us to begin evoking the memory and voice of the person that's died so that they can become an ally in the treatment, in our work together. So it's not just between you and me, but whoever has died, I want them included in terms of their voice, because they can often be much more supportive than I could ever be. So these are a couple of the primary lessons I wanted to get across to you before we began talking. I guess I had a couple of PowerPoints here. This first, we have a website, www.vdbs.org, Violent Death Bereavement Society. And a lot of material is there if you get on that website, including our manual, which you can download for free as a PDF It's about a 70 or 80-page manual, and it goes through all of the details of the 10 sessions. So since 1984, we've worked with over 3,000 adults with traumatic grief after violent dying. The service is sponsored by grants so that it's free, individual and group therapy. Trainings, there have been local and national and international. University of Washington sent me over to the Middle East, where I worked in Gaza, in Israel, in Syria, in Lebanon, in Jordan. Our manual is translated into Arabic and Hebrew. You'll see that when you download the manuals. Also a manual for correctional facilities because of the work I've done in prisons. And we've been doing research in terms of outcome data with over 300 subjects that have gone through our groups. And as I said, that I've published a couple of books and articles, and we've entered the kingdom of the evidence-based, which is, of course, the only way you can get anything published nowadays. But these have been pilot studies. I don't show you a lot of that because pilot studies, I think, are confirmatory of the fact that people aren't getting worse with our intervention. There aren't a lot of them that are dropping out, only about 20%. We haven't had any casualties. And of course people get better with measures of complicated grief and PTSD. Almost anything that we do, if it's thoughtful and follows certain principles, which I don't have time to get into because I'm not going to lecture, but all of us that are doing short-term work with grief or with trauma, if we are stabilizing people before we begin doing reframing in terms of dealing with the trauma, with exposure, and then followed finally by a phase of consolidation and reintroducing people to their previous role, because this is a rite of passage that people are going through after in a grief reaction in terms of establishing a different identity, as I say it. And I think all of us are following certain principles with short-term therapy so that all of us are having results that are positive. I think what the studies that need to be done are, and Sid's going to talk about this, are studies where we're comparing different interventions to see which is more effective for different forms of dying. There's my personal email address. If I could be of any help, you wanted to communicate with me. The dual process of grief is, I think, the most meaningful, meaning that there are polarities of this rite of passage that people are going through. There's a polarity associated with the person that's died, and the polarity which is difficult to surrender, and the polarity of getting back to life. And I think what happens with violent dying is that the dying narrative overshadows the living narrative, and that in treatment, reducing the trauma distress, stabilization takes precedence. That's what we have to focus on initially. And this is the dual process of strobe and shoot, of these two poles that we oscillate between as we are prevailing over any kind of death. Loss-oriented, reunion-oriented. Separation distress, and attending to life changes. Resurrection, which is alluring, and having to develop a new role, new way of seeing things. Breaking bonds of care seeking, that to some extent the only way I've been able to stabilize myself is with this connection with this important self-referent that I've lost, and I search for them because I need their care. And denial, which is avoidance of change, finally beginning to oscillate away from that. And this is what I think happens with violent death, which overshadows the loss-oriented because of the traumatic dimension. Trauma, distress, horror, and helplessness associated with violent dying, which takes precedence over separation distress in presentation. Reenactment imagery, which is intrusive, rather than resurrection imagery, which is alluring. Breaking bonds of caregiving in addition to care-seeking. It's mothers who have lost a child who are trapped in this narrative with a double bind of not being able to leave it because somehow they have to make it unhappen. They have to be there in the image with no role in themselves, for themselves, in the imagery. And it's more caregiving than it is care-seeking, which takes a different approach in therapy. And nihilism about change, particularly after a homicide. And 50% of parents who have lost a child to a violent death, Shirley Murphy did this study, have been unable to establish any sort of meaningful concept about the dying at 5 years. I think that's comforting for particularly mothers to know that prevailing rather than recovery is the norm, that 30% of mothers in a community sample, these aren't people that are coming in and asking for help. 30% of people in a community sample, particularly mothers, are going to remain traumatized at 5 years. Does that mean they have PTSD? No. I think they're not disabled, but each time they begin to think about the dying of their child, they're still having reenactment imagery that still gets triggered. And I think that's reassuring for mothers in particular to know you're not going to get over this quickly. You can't be pressured to get better in a year. This is going to go on the rest of your life. And our objective has to be to somehow carry this experience forward into your living, not to extinguish it, not to make it go away, but to come into balance with it. That's the model that we try to establish with restorative retelling. So I wanted those you to have those introductory remarks and a little bit about myself and the importance, I think, particularly with suicide, to establish how elective it was or how inevitable it was in certain circumstances that shapes and shades the traumatic dimension.